Hey guys, welcome to a presentation on esophageal balloon catheters and using them to record transpulmonary pressures. So some objectives for this PowerPoint are to learn the significance of transpulmonary pressure monitoring, how to place balloon catheters, how to take readings, and use those readings to implement ventilator changes. So the traditional definition of transpulmonary pressure is taking the pressure at the airway opening and subtracting the pleural pressure. But an alternative definition, um, we can use the alveolar pressure as a substitute for the airway opening pressure because they're the same um, under static conditions. And for us, that means during an inspiratory hold or an expiratory hold. So on this slide, we just have like an anatomical display of different pressure gradients and also representation of the balloon placement right here. Kind of sits right behind the heart. So why do we want to measure esophageal pressure? Because we can measure the stress on lung tissues, we can monitor changes in pulmonary mechanics, we can use all these to optimize our vent settings and prevent ventilator-induced lung injury. So some indications for wanting to do this are using protective lung strategy, preventing overdistension or barotrauma, and then preventing alveolar derecruitment and also atolic trauma. So some contraindications of placing a balloon are esophageal ulcers, tumors, diverticulitis, esophageal varices, any recent surgery along that tract or the nasal pharyngeal area, because we can also place the balloons nasally instead of orally, and then any like nose bleeding going on. Factors affecting our pressure readings. I'd say the number one factor for us and where there's most room for user error are proper balloon inflation. We'll go over this technique a little later. Gravity, meaning patient positioning, um, consolidated lungs, cardiomegaly, pleural effusions, and abdominal distension. So, other than the balloon inflation, the thing that all of these other things have in common are putting pressure up against the lungs, like pushing up against the lungs. So, this can affect our pressure readings. Some limits and concerns, just things to keep in mind when we do this is that not all diseases distribute evenly. Some examples of this could be like lung cancer or, unilateral tumors just on one side of the lung. Maybe the patient's had a lobectomy or a pneumonectomy. Um, Patient abnormal anatomy. So this could be like chest wall deformities or like scoliosis, things like that. Pectus excavatum, pectus carinatum, um, spontaneous breathing efforts. These are what we want to avoid when we're trying to take our readings because any patient effort is going to throw off our inspiratory hold or expiratory hold, and we're not going to get a very accurate reading at all. Other things, balloon elastance, and then just properties of the esophagus. Um, how gravity can affect our readings and intra-abdominal pressure. So this is like maybe an overdistended abdomen, things like that. Oh, and back to the gravity thing. Um, this could be like patients on CLRT, or maybe we're proning a patient. It's definitely gonna. It's just you just want to keep that in mind when we're taking our readings. So we can place the catheters orally or nasally. And to calculate the depth, we take the patient height in centimeters and multiply it by 288 or 0.288. I just like to think of this as either 28 or 29%, and that just gives us a rough estimate on how deep we should the catheter should sit. But another way to estimate placement depth is just kind of similar to how we um, decide which size oropharyngeal airway you want to use or nasopharyngeal airway, you can take the catheter and actually just hold it up to the patient, and you want the tip of the catheter to sit about the xiphoid, where the xiphoid process is. Another rough estimate is about 35 to 40 centimeters from the teeth. So when we inflate the balloon and take our measurements, there's actually only 1 ml of air inside the balloon. But when we fill it up, we actually fill it up with 3 mLs first and then slowly withdraw the 2. And the reason we don't just put 1 ml in to begin with is because we could have like some localized balloon inflation like you see here. And then we're not getting like an even reading across the balloon. So for placement technique, you want to inflate the balloon with 3, or actually you want to check the integrity of the balloon first before you do anything, place any lines in the patient. So make sure your balloon doesn't have any leak, then you want to keep it deflated. You can use some topical anesthetic or like lidocaine jelly, or you can just use water-soluble lubricant. So you want to place the patient's head in a neutral position or tilt it slightly forward, and this helps close off the trachea and ensure you're going down into the esophagus. You want to insert the balloon about 50 to 60 centimeters or 15 centimeters past the calculated depth with the formula we just saw, because you want to go past that point because we're going to inflate the balloon with the 3 mLs, withdraw the 2, and we're going to be looking at our waveforms and slowly drawing back until we see cardiac oscillations in our esophageal pressure waveform. You can also change the waveforms time scale on the ventilator to kind of zoom in and get a better picture of your waveform reading. So this is just an example of the cardiac oscillations, these little up and down movements here. This is the heart beating, and it should correlate with the heart rate on the patient monitor. Once we see these, we know we're in the right spot. This is proper placement with the chest x-ray. As you can see, it's sitting right behind the heart, right about where the xiphoid process is. The balloons we use here at Cottage are kind of hard to pick up, but yeah, just be on the lookout because this is you want to get a chest X-ray if you can after you place the balloon. So confirming placement, we already went over the cardiac oscillations in the chest X-ray. You want to check out your pressure waveforms. Your airway pressure waveform and your esophageal pressure waveform should be correlating with the breaths. Um, and then if you were in the trachea by accident, I mean, you'd probably see other signs. Your patient might be coughing or something, but your esophageal pressures would also be similar to your airway pressures. Normally, there's a bit of a difference between the two numbers. So setting up waveforms on the G5, you want to go to this graphics tab, and then this box will pop up and choose layout 1 so we can get a bunch of different waveforms listed. Oops. Here, so setting up the waveforms. The order I like to do it is have the flow waveform on the top, the airway pressure waveform next, the esophageal pressure waveform, and then very last, the transpulmonary pressure waveform. I like to do it in this order because when I'm looking for a good solid reading, um, we want to make sure our flow's at 0, so I can look right at the top. And once I know my flow's at 0, I can follow these numbers down, and this is the order we chart in, and it's also the order of the equation, because we take our esophageal pressure and subtract it from our airway pressure, and that gives us our transpulmonary pressure. So using this three-way stopcock that comes with the balloon is probably the most tedious part of taking the pressure readings. Um, so you want to connect the balloon to the end that connects to the ventilator, and then you want to make sure that the valve is open to both the balloon and the ventilator, and also open to air. Then you want to withdraw or fill up 3 mLs of air into your syringe and attach the syringe while the valve is open to each thing. Um, I would like to kind of stress to leave in just a hair, or go a hair below the 3 ml line, because the second you attach this, you're going to see your esophageal pressure waveform immediately go positive. See above here how it's not 0, and you're going to have to withdraw um, a little bit because you want to zero it out. Once it's zeroed out, we turn the stopcock. Um, yeah, so once you're zeroed out, you turn the stopcock counterclockwise, and this closes off um, everything from the ventilator. You'll put 3 mLs in to the balloon and then slowly draw 2 mLs out. I do this over about 15 to 20 seconds. You don't want to do it too fast because it can mess up the deflation of the balloon and make it uneven. So once you've withdrawn the 2, you want to turn the stopcock counterclockwise again, and then you can see that the valve is just connecting the balloon straight to the ventilator. And then you're ready to take your readings. So I just want to go over conventional methods of setting tidal volumes and PEEP um, as compared to transpulmonary monitoring guided pressures. So conventional tidal volume for you and me is probably about 6 to 3 mLs per kilo of ideal body weight, or roughly 5 to 7, somewhere in there. Commonly used initial settings are 6 to 8 mLs per kilo. Sometimes we can even go down to 4, and this is kind of following ARDSnet. You'd maybe use 4 mLs on patients with really high airway pressure, such as status asthmaticus patients. You want to keep those tidal volumes low. But conventional methods for setting PEEP, traditionally, at least when I was in school, they always taught us to just start off at 5. Here at Cottage, we like to go up to 10, especially on our neuro patients. But patients in acute respiratory distress syndrome typically require higher PEEPs, around 10 to 15, and ARDSnet is a pretty popular guideline followed everywhere. Oops. So let's see. Optimal PEEP. So what is optimal PEEP? It's like to reflect that a negative transpulmonary pressure reading means that your lungs or your alveoli are collapsing on each breath, kind of like we're seeing here on the left picture. Of course, this is just a test lung, and it's a little bit dramatic. But when your alveoli close like that and then open back up every breath back and forth, that can damage the tissue. So optimal PEEP is the level of PEEP that keeps them recruited and nice and open on after exhalation. So to measure this optimal PEEP, we take our total PEEP and then we subtract our esophageal pressure on the expiratory hold, and that gives us our transpulmonary PEEP reading. So to find optimal PEEP with the balloon inflated, we want to perform an expiratory hold, measure that total PEEP, which is right here in our airway pressure reading. So we want to scroll over after we do the hold, make sure it flows at 0, and we get a nice flat waveform all across. So our total PEEP is from this airway pressure waveform right there in this example. Um, looks like it's about 5. And then we subtract our esophageal pressure waveform reading, which is about 10, and that gives us a transpulmonary PEEP of -5. So again, when that transpulmonary pressure reading on our expiratory hold is negative, our our lungs or the alveoli probably collapse like this. And that's not a good thing. We want the transpulmonary PEEP to be at least 0. So if you have your balloon inflated and you're just looking over at the vent and you're looking at your transpulmonary pressure waveform, and you see that it's going below 0, you can automatically tell that your patient probably needs more PEEP. Um, so what is driving pressure? Driving pressure is a measure of the pressure difference between plateau pressure and total PEEP. You can think of it as the amount of energy applied to the lung. Um, so the higher that energy is, the greater the potential there is for lung injury. So here's the equation. We want to take our plateau pressure and subtract our total PEEP. Our total PEEP um, equals our PEEP plus our auto PEEP. So we want to substitute our total PEEP with the esophageal pressure taken during the inspiratory hold. Um, so we would take our plateau pressure and subtract our esophageal pressure during the inspiratory hold, and that gives us our driving pressure. So to measure driving pressure, we want to make sure our balloon is inflated, perform the inspiratory hold, scroll over to a nice flat plateau, make sure our flow is at 0, and then we take our airway pressure reading, subtract our esophageal pressure reading, and then that gives us our transpulmonary plateau reading, or our driving pressure. So here we can see it's 25.9 is the plateau pressure. We subtract the esophageal pressure, 12.3, and that gives us the driving pressure of 13.6. Um, Here at Cottage, we like to keep the driving pressure below 15 is our policy. But you can find some other studies that say maybe even going up to 20 is acceptable. I think I've even seen one that said up to 25, but the lower the better on this. So potential reading issues, again, proper balloon inflation using the three-way stopcock. Um, Got to make sure we're all doing that the same um, and that we're taking consistent readings. Um, so you can have a flattened or dampened waveform if the balloon isn't inflated properly. And then also spontaneous breathing efforts from the patient. Patient motion, such as shivering or posturing, which we see a lot in our neuro patients. Any leaks in the balloon itself, but also in the ventilator circuit, or also potentially if your patient has something like a chest tube. And then definitely tracheal placement. So again, normal values, we want to keep the driving pressure or the pressure that we get when we do the inspiratory hold, we want to keep that below 15. And this is to help prevent lung injury. And then our optimal PEEP, we want it to be at least 0 or even up to 5. Um, because again, if it's negative, we're probably causing adult trauma. And then also, of course, it's going to help um, improve oxygenation. So making changes, you just do the math. So if we do our expiratory hold and our transpulmonary PEEP reading is -6, then we just want to go up by our PEEP by 6. Again, because we want to be 0 to 5. And then making changes for our driving pressure. Driving pressure is affected by increasing or decreasing the tidal volume or inspiratory pressure if we're in pressure control mode. So basically, if our, our driving pressure is high, then we would want to go down on our tidal volume, or vice versa. If we're low, we know we have some wiggle room to go up, maybe potentially if we're having CO2 elimination issues. And then keep in mind that lung compliance is going to affect um, those pressure readings. If a patient has low lung compliance, they're probably going to need, or their driving pressure is probably going to be high, and you're going to want to aim for lower tidal volumes. So monitoring changes, you want to check the insertion site for breakdown. You want to maintain proper placement depth. And then, of course, we can check how our changes are affecting our blood gas. And when we implement changes, especially on PEEP, We want to keep an eye out for hemodynamic changes because some patients I've had where after placing the balloon, we've gone up to a PEEP of like 22, 24. Just remember any change, and PEEP can increase your intrathoracic pressure, decreasing venous return and dropping our blood pressure. So in conclusion, um, these pressure readings rely on the esophageal manometry. We're assuming several things, and there's a lot of potential errors in these readings. Again, that brings to mind like not all diseases are affected evenly or like symmetrically across the lungs. Patient positioning is going to play a factor. Um, and then recent investigations demonstrate improved oxygenation in ARDS patients when the PEEP was adjusted, and um, there are different methods for estimating transpulmonary pressures, and also we want to keep in mind what our goal is. Um, and after we make changes, after the patients get better, we can take new readings and then further adjust our vent changes. Um, there's definitely more research that needs to be done to refine these techniques and um, guide our ventilator changes. And that's it. Thanks.